Good afternoon. It is so wonderful to look out and see this audience and so many friends of the Ford School, members of the community in the Ford School for what I know will be a really enriching and important discussion for so many of us and our overall community. Good afternoon, everyone. I am Celeste Watkins Hayes. I'm the interim dean of the Gerald R. Ford School of Public Policy here at U of M, and I am also the founding director of our Center for Racial Justice here at the Ford School. It brings me great joy to welcome two very special people to the Ford School. My colleague, friend, partner in progress, Charles R. Eisendrath, director of Wallace House, Lynette Clementson, and the esteemed educator and writer, Linda Villarosa. Linda is a contributing writer at the New York Times Magazine, where she covers race, inequality, and public health. Her 2018 Times Magazine cover story was a finalist for the National Magazine Award. I assigned that in my courses for years. She is also the author of Under the Skin, The Hidden Toll of Racism on American Lives and on the Health of Our Nation, which was named one of the best books of the year by the Washington Post, Time Magazine, Publishers Weekly, and NPR, and it was listed by the New York Times as one of the top books of 2022. As a scholar who has spent many years researching HIV policy, I have followed Linda's illustrious career with admiration, as she has been on the front lines of shedding light on the HIV epidemic and its disproportionate impact on communities of color. Linda is both a storyteller and a truth teller, leading with compassion and integrity, all the while offering sharp analyses of our most pressing issues. So without further ado, please join me in offering a very warm welcome to Lynette Clementson and Linda Villarosa.
Thank you. And Celeste, if we can have you come here, we're going to get to a part in the conversation where I'm going to involve our guests down here in front in the conversation. And I thank you all for joining us. The Wallace House Center for Journalists here at the University of Michigan runs two programs, the Knight Wallace Fellowships for Journalists and the Livingston Awards, and we run the Wallace House Presents event series here on campus. And a really smart reporter from the Michigan Daily asked why we were doing this particular event today, and I told her that first and foremost, Wallace House does events on campus because it is part of our mission to make sure that the public really understands the vital role that journalists play in our society. And for policy people to be able to do things, the public needs to know about them. And the public knows about things because journalists write about them and scholars research. And so the work of scholars, journalists, and policymakers are intertwined. And so Linda and I are also intertwined. So we've worked together in various capacities over more decades than either of us would like to admit. And so you are kind of getting two girlfriends and partners in crime talking here today about a subject that is important to both of us. And I just want to thank Dean Celeste Watkins Hayes, not just for her leadership of the Ford School, but for those of you who might not be aware, the Center for Racial Justice is relatively new here on campus. Celeste and her associate director, Dominique, created this and set it to live in the Ford School, again, because if we are as a society to pursue racial justice as an imperative, it starts with policy. And we can wish for things, but policy helps to make things true and law, which is important. So thank you both for having us here and being co-sponsors of this event. So Linda, it is so great. I've been waiting to be here to talk with you. If you all noticed, we have Linda's book outside for sale. being sold by Book Suite, our bookstore on the north side of Ann Arbor that I want to give a plug because I want it to stay there on the north side of Ann Arbor as a healthy bookstore. And Linda will be sitting right here signing books after the event. So I encourage you to check out the book. We're also taking questions by question card. You may see small cards at your seat if you have a question and don't have a card. My colleagues Melissa Riley and Jason Rose have the cards, and if you raise a hand, they'll pass out a card to you, and we'll take them up front. One of our Knight Wallace fellows, Makita Easter, will be bringing the questions to us when we get to that portion of the conversation. Makita is also following Twitter. And so for those following on the live stream, if you have a question, Melissa, is there a hashtag? Just at Wallace House? At Wallace House, make sure to include that on your question, and Makita will make sure that it gets included. And we have with us also down here next to Dean Watkins Hayes, Professor Arlene Geronimus, whose research factors prominently in Linda's reporting. And so when we come to bringing the room into the conversation, I'm going to invite both of you to offer some of your long years of research and wisdom on these topics. So Linda, in the bio it mentions the New York Times Magazine, and I know that here in a place like Ann Arbor, the New York Times Magazine is an important thing. Linda and I have both worked for the New York Times, and we worked there together. I actually came to know Linda's work and respect and follow her because she was the editor of Essence. Who in this room is familiar with Essence Magazine? Yay, more people than I thought there would be. So, when I was just becoming a journalist and early in my 20s, and I was a fan of women's magazines, and I felt that when most women's magazines were sort of writing about 5 ways to please your man, Essence was always
doing that, but
did that. It might not be on the cover, but Essence always felt like it was addressing me as a woman more holistically, my own health and well-being, my role and space as a Black woman in America, how I would make myself healthy, how I would make my community healthier, and it just seemed to have a bit more of a mission than a more holistic mission than some of the other magazines that I also enjoyed. And so that's how I came to know Linda's work before she and I had a chance to work together. So I was really intrigued when I started reading your book, Linda, that all of the decades that you have been writing about health disparities, women's health in particular, that there came a point in your reporting career where you began to think that you had it wrong, or if not completely wrong, there were some things that you didn't have quite right. And so that's where I'd love to jump in today to talk about your journey in understanding where race and racism fits into the health of our country.
Well, first, thank you, everyone, for coming, and I'm so happy to be here with you. Well, I think that because Essence Magazine was about uplift and self-help and empowerment, that in every way, it included health. And so my theory in my head was, I see that there are racial health disparities in America, beginning at infant mortality and all the way to the end of life with life expectancy. Black people live fewer years, and babies are more likely to die than the white population. And what I thought is, if I just do the each one, teach one, lift as you climb kind of mentality, and just really say, okay, everybody who's reading this magazine, and Essence had a huge reach. It reached like a huge part of the community of Black women in America. Just tell everyone to do everything right, take good care of yourself, and I would blindly say, go to the doctor and follow the rules and do what you're supposed to do, which in many ways I do believe that for individuals, but then I started to realize little by little, especially as I learned about public health, that that isn't going to change what the status of Black people in America. It's not going to significantly change those health outcomes because something else is going on that's about structural and institutional issues, not just about making people responsibility for the health of the race itself.
And we're having this discussion today as part of the university's MLK Symposium. And so I think we should also talk about this and its tie to civil rights, racial and social justice, and a famous quote that was mentioned yesterday in the keynote address for the MLK Symposium from Dr. King that you told me has been corrected over the years. So let's get the quote. It was from 1965?
66.
1966.
Well, here it's even some of that is the snippet is taken out of it, but I'm going to read the whole quote. This is March 25th, 1966 in Chicago, Martin Luther King. We are concerned about the constant use of federal funds to support the most notorious expression of segregation. Of all the forms of inequality, injustice in health is the most shocking and the most inhumane because it often results in physical death.
Yeah.
So it's even when it's kind of like misquoted a little bit, it's health care, not just health. And then it's also inhumane, but he really said inhuman. And inhuman has a kind of insidiousness that's worse. And health care is just part of the issue. It's often about the lived experience of Black people in America.
Which is health.
Which is health.
Holistically.
That's right.
Yeah. And so what led you to thinking that you needed to, in your own process as a reporter, write this book? And what was your aim with this book?
Well, one thing was really funny. It was funny because you were saying you assigned my story in class. So a lot of people were assigning my stories in class, and then I realized that people were cobbling together a kind of book of some of my articles. And I'm thinking, well, that's ridiculous. I have people Xeroxing and asking for permission and all this stuff. Why don't I just pull it all together in one place? But I also, at first, I had to be convinced that this was a good idea. I said no a bunch of times. And partially because I thought everyone knew all the information, and that wasn't true. It wasn't really pulled together in one place for a kind of a consumer audience. So I had to really acknowledge that. I also realized that this could be a game changer in medical education. And my daughter, who's 26, pointed this out to me when I was talking about the importance to medical schools and medical students. And she said, you have to think about the importance it is to individual people who feel like they have done something wrong if they get ill. They've done something wrong if something goes wrong in childbirth and pregnancy. And they're blaming themselves and being blamed. So lift up the stories of individuals that say, wait a minute, this isn't me. This is widespread, it happens to a lot of people, and it can't only be blamed on individuals.
Just so we have some grounding for people in the room who are coming at this topic fresh, I want to go back to some historical touch points that you mention in the book. We're not solely going to be talking about women's health here, but I do want to start with women's health because I think some people are surprised that the entire field of obstetrics and gynecology was created and perfected as a type of medicine by experimentation on the bodies of Black women. So can you talk about that?
Well, it was interesting. When I talk about J. Marion Sims, who was considered the father of modern gynecology, and there's actually a Sims speculum that is still in use, named after him. I'm talking about him because he, in the 1800s, mostly in Montgomery, Alabama, he was trying to find a surgical remedy for fistula, which is an extreme side effect of childbirth. And he was using mainly 3 enslaved women, Betsy, Anarcha, and Lucy, to experiment on. And what he did was he would practice the surgeries without anesthesia. For some of the time, there wasn't anesthesia, but then when it came into wider use, he still didn't use it, under the notion that was widespread and believed at the time that Black people didn't feel the same kind of pain. So when I'm reading his book, his biography where he described these experiments, he said that sometimes the women were under such, excruciate, it seemed like they were, in pain, but he didn't acknowledge that it was actually hurting him. There was some kind of hurting them. It was some kind of disconnect. And also he said he would have one hold down another because she was trying to escape while he was doing this experimentation. And until recently, he was widely considered the father of gynecology. Now, in New York, it was really exciting when his statue got taken down. It was in Central Park, across from the National Academy of Science. And part of the reason it got taken down was a sustained protest of women wearing hospital gowns stained with red paint in honor of the three women. And in Montgomery, his statue is still up. And there's a sculptor who is there, and she made life-size sculptures, which she calls the mothers of gynecology, of Lucy, Betsy, and Anarcha. So if you ever are going to the Legacy Memorial, it's walking distance to see these beautiful sculptures. So I like that there's activism that can happen, just to get rid of some of, these old, I sometimes get pulled into those conversations about, should you get rid of Civil War memorials? I'm like, you know what, I'm focusing on this thing. This guy was terrible, and it's proven, he described it himself, so why should he have a statue?
And I think it's worth making the historical note now, because I think it would be easy for people to say, that was a terrible thing that happened a long, long, long time ago. And that was terrible. But the underlying belief about Black people feeling less pain and having thicker skin, literally thicker skin, those myths have persisted in medicine. And there are current studies that reference Black people being prescribed pain medication less for similar treatments because of the belief that they can withstand pain somehow, that we can withstand pain in a way that other people cannot.
In the book and in some of my work, a lot of us quote this study from 2016, the University of Virginia, which asked medical students, white medical students, about these myths. And it was thicker skin, different nerve endings, blood coagulating differently. These were myths, and that Black people have more tolerance to pain. And 40% believed at least one. And so that is alarming that in 2016. In 2016. Then you can just keep looking at these studies, but in 2019 there was one out of the University of North Carolina about pain during C-sections. And even when Black women, birthing people, complained more of pain, it was less acknowledged and they were given less pain management. So a C-section is painful, it's surgery, and to not get adequate pain treatment because there's a myth floating around that began during the years of enslavement is scary in this day and age.
Yeah. And so if we move forward, I don't necessarily want this conversation to be a chronicle of Black pain over the decades, but there were numerous sort of periods, whether it's forced sterilizations or, that lead up to a part of the book that you spend a lot of time on, and it is disparities in maternal mortality and the death of babies at childbirth. And as advanced as we are now, there are some, I think, shocking statistics about a Black woman's chances of having difficulty during childbirth in our very advanced medical system.
And I think the reason I got involved in it is I was looking at infant mortality. And it's kind of like, was looking at that and seeing why are black babies more likely to die. And then I'm looking at research around it, and most of it was saying, well, at first they thought there was a preterm gene. So then they were like, okay, there's no preterm gene, that's wrong. And then it was like, well, the people that this happens to are all impoverished or lack access to health care. And then there became more studies that were, no, it's not that. And then the one that, the statistics that really got to me was that black women with an advanced degree is more likely to die or almost die related to pregnancy and childbirth than a white woman with an 8th grade education, which speaks to the, to say, and also the disparity is greater at the more educated end. So the bar graph looks like, these are black women, these are white women. And then, if you look at the black women graph, it's higher than the white woman with an 8th grade education, and the gap is bigger in the more educated way group. And certainly, education is a proxy for all the good things that you should be able to, it's a proxy for knowing what to do and how to take care of yourself, for having access, health insurance coverage, for having a good doctor. But that isn't protective to black women. And so the only thing it could be is something related to racism.
Racism. So, I mean, that's the subtitle of the book, The Hidden Toll of Racism on American Lives and on the Health of Our Nation. I want to focus a little bit on the second part of that, on the health of our nation. We could sit in here and have the room filled with only black women and have a kind of essence conversation about how, why this was pertinent to us as women. But why is it important for the health of the nation? And what is that link? And what would the takeaway here be today?
Well, I think, I was so in the black space for so long, but looking at it wider was kind of even more horrifying in some ways. We're the richest country in the world. We spend more on healthcare than any other nation in the world. Yet we, just as a country, not just the black part, but we have the highest rate of infant mortality and maternal mortality compared with other wealthy countries. And then we also have the lowest life expectancy compared to other wealthy countries. So why, if we're spending so much money, is it not buying good health? And certainly everyone, also we have a problem with the lack of access to health care. And, everyone, care should be a human right. We should have universal health care. But even if we give everyone access to this health system that's broken, it won't change, it won't fix this problem totally. And a lot of times I get in arguments about that lack of that access to health care thing. And I had an interesting experience not long ago where it was sort of like people from the community talking with people who were healthcare providers. And all the healthcare providers were saying, oh, if you just had more access to healthcare, if you had access. And the people from the community were like, well, many of us do have access to healthcare, but we don't want to be involved in the system because we get harmed by the system. So that was a disconnect saying, oh, if you just had access, and then people are saying, no, we're often avoiding this system because we've seen what could happen. And that is saying just sort of widening access to a system that's broken will not fix the problems we have in this country.
But if you're talking about racism, it's easier to define, perhaps in a historic context, where it is scientific experimentation on women without regard for their pain or their outcomes, or even closer history, the Tuskegee experiments, or Henrietta Lacks and the stealing of her cells for scientific advancement. So those are long ago history and nearer, but still history. Is it a little bit harder to talk about and to use the frame of racism in a modern context where much of the disparity would not be intentional?
I think I am sometimes loath, and definitely as with this, on this book jacket, I was not, this is a new subhead. It did not say the hidden toll of racism. It said something like race, inequality, and health. And then I started thinking about it. If I don't say the words, if I don't say the word racism, then when that's what the book is telling me, that's what the facts are, that's what the evidence is, then I'm, and I was worried about hurting people's feelings, and I was worried about healthcare providers that would feel bad. And then I was like, well, this is what this is about. This is what it is. And I think it struck me not long ago when this book was reviewed by the New York Times Book Review. Really good review on the front page of the book review. And it was a very well-written review. And right in the middle, the author, a Black woman of the review, went into her own near tragic birth story. And she blamed herself. And I just thought, well, this was June when this book review came out. This woman's child is young. And I also thought of Dr. Susan Moore. So Dr. Susan Moore was a physician in Indiana. And she went into the hospital with COVID in 2020. She was trying to communicate to the healthcare providers caring for her about what the protocols were, and she was shut down. Then she was in extreme pain, and she asked for pain medication, and she said that they treated her like she was drug seeking. And what she did was, from her hospital bed with tubes in her nose, she took a Facebook Live video and put it online, and she explained what was going on with her. And
As a physician?
As a physician who was ill. So then she got out of that hospital, but ended up dying of COVID. And in the investigation of the hospital system, one of the things that they found was the hospital staff was intimidated by her medical knowledge, and it may have affected her care. So that, to me, is saying there are stereotypes that are left over where if you are trying to be competent or even speak up based on your medical knowledge, you're seen as angry and out of control. And that seems like that's what happened to her, and that's what she felt. And the thing that she said in that video that really made me get goosebumps was she said, "This is how Black people get killed." She said it over and over, "This is how Black people get killed." And then she did, in fact, die. So I think that we have to say the word racism in the current context.
And have you found in talking to people about the book since it came out that the use of the word racism on the cover and so directly in the text makes some people shut down and disassociate themselves from what you're saying in the book? Because I think people don't like to be implicated in racism.
Right. And I try to say it as gently as possible in a non-blame context, that it's systemic, that it's institutional, that it's structural. So, because I don't want people to just shut down, because that will not lead to change. But I gave a grand rounds recently at a OBGYN, department at a major hospital in my city. And I could see the shutdown happen. I talked to a friend after. I said, "Wow, no questions at all in the Q&A." She goes, "Oh, no, the people had shut down. They did not want to hear that, what you were saying." But I've also seen where there's been community engagement and at a hospital in New Orleans, where I spent so much time, and they listened to what they were told. They listened to the investigation. They read my story, which took place in New Orleans, and they made change. They ended up opening an obstetric emergency room and also incorporating anti-racism training for their staff. And so I thought that was, and I think what worked in that situation was in the public conversation, in the community conversation, they also brought in someone who had a good experience, who said, "I had a good experience by your physicians, but there was a problem with me getting care right away, not the fault of the hospital." So they got, "No, you did good, you did what," so it was calling out and also kind of calling in a good way.
I want to bring in Professor Geronimus here, because while we're talking right now about sort of direct results of things that happen in the process of medical care. One of the themes that runs through the book and that I find really fascinating and sort of I really had to step back and think about all of the ways that I knew or wasn't aware that this was true, is the effect of racism in the United States, not just at a transactional level in a medical setting, but on the health of Black people over time. And in your reporting, you reference Dr. Geronimus's work on something called weathering, the concept of weathering, which has been the focus of your research. Can you just talk a little bit about what weathering is and how it applies here?
I want to take a moment to say thank you, because that was a game changer for me, discovering you, talking to you, and not just talking to you once, but to keep talking to you about this so that I could even expand my thinking and make sure I got it right. So thank you.
You're welcome. Sorry.
So this is Professor Arlene Geronimus from the School of Public Health here at the university.
Weathering is a concept that I began thinking about as a metaphor, but over the 30 years that I've studied it, I now see it and can explain it with plausible biological mechanisms as an actual biological process. And it is about how living in that one way that racism could have these effects that we're talking about today is that it leads to people having to be constantly vigilant, and that has a physiological effect that chronically erodes your immune system, your neuroendocrine system, your metabolic system, other body systems. And so you, in effect, are, you become biologically old sooner than you are chronologically old. And this would happen to anybody who's human. This has nothing to do with any alleged race genes that really don't exist anyway. My own work, I've looked at it in the Latinx population, Appalachian whites, and in the book that I'm about to publish.
March, people. It's called Weathering. March. This March. Got to get it. And have her speak.
Thank you. In my own history, which I think is part of why it resonated with me, or I thought about it, as a daughter of working class people who were children of immigrants, I see how weathering applied to my own parents and grandparents' lives. I didn't necessarily understand that when I started, but it is sort of funny how that catches up with you eventually, and you realize, well, people always ask me, why did you start studying this? And I have all these stories, but I think in the end it may be because of my parents and grandparents, though they did not understand this phenomenon. Anyway, I called it weathering because weathering means both this erosion, being weathered, and it also means endurance and resilience. They weathered the storm well. They weathered the recession well. And I believe that weathering is a biological process that happens because of both those things that, in the case of Black women who we're talking about today, but also in other populations, are called upon to, with so few resources and so few support and against so many headwinds, still weather in the side of weathering that is agentic. They have to work very hard. And so I've always thought weathering turned the entire idea that it's your individual behavior or lack of personal responsibility on its head, because it's actually working hard and playing by the rules and fulfilling the American creed under horrible structural constraints, whether they're economic or whether they're in terms of racist stereotypes or all kinds of disadvantages that racism has both historically and continues to maintain, that in fact, that requires extra high effort coping, and that among all people in a population that is structurally racialized, but for those within it who work the hardest and are most in sync with what we think of as the American creed, and that's often women in the case of the Black community, that they suffer greater weathering, and that plays into maternal mortality, high rates of obesity, diabetes, hypertension, and early death and disability.
One thing that I learned from you is that, when I was asking you, is weathering a Black thing? Not the gene, but just is it only affect Black people? You pointed me to the study about the Latinx community in Postville. And you also ended up sending me to West Virginia because I asked my editor, I was like, is it, this is a Black book. I'm only writing about Black things. What do you think about that? She goes, well, why don't you just do a white chapter? I mean, it's just like other books. It's like, there's that one chapter about the Black people, so you could do one about the white folks. So I thought of what you said, that, it's anyone who has to battle against discrimination, who is having to be vigilant. So I thought, where's the worst place where I can see that in America? So during the pandemic, I got in my car and I drove to West Virginia, and sure enough, and the thing that struck me as an observer is that I kept asking people how old they were and getting it wrong. So I'd see someone who's like, I'm like, he looks 70. And then I'd ask the person and he's like, oh, I'm 48. So people just looked older because of all that they were going through. And I thought, oh, this is going to be my white chapter. So.
Yeah. And you the terminology, you use, it's very bracing in the book and in your talks, that Black people or anyone who's subjected to this weathering, but in the context of Black people in this book, live sicker and die quicker than the rest of the population.
Yeah.
Which is not, that's rough, Linda.
I know.
Like how are we supposed to sort of find some hope and a path forward from that, if that is sort of a documented fact?
Yeah. Well, I think for me, I describe myself as a happy person that writes about sad things. And, I think as individuals that, I would go back to that advice I was giving at Essence all those years, is like, just do your best to take care of yourself, find happiness. I have a lot of, I don't really hold in this, I hold the people close, but I don't make it so that my heart hurts so badly that I can't do my work. I also believe in social change and social justice. We had a family conversation, and my mother's 92, my children are, young folk. So it was my mom's 90th birthday, so we were talking about politics, which is a mistake. Except this was really good, because we were talking about social change, and my mother was like, you just gotta vote. When I was coming up, you couldn't vote, and they stopped you from voting, so now you have to vote. And so the kids were like, voting is nothing. You have to abolish the whole system, abolition, abolition. So my partner and I are kind of like in the middle. We're like, well, everybody has them. Yeah, that's good. But
You should vote.
You should vote and then
burn it down.
That's basically it. But I do believe, and I do see change happening. I'm really excited about what's happening at medical schools, where it's the students coming from the ground up, medical schools, nursing schools, midwifery schools, PA schools, the ground up. It's coming from students who are saying, we do not want to be using these outdated textbooks. We want to be different kinds of medical providers once we, enter the profession. And I find that really exciting. And I find it, and it's also health policy people. And, I'm often preaching to the choir, but at least there's a choir, and it feels like the choir is getting bigger and louder.
Mm-hmm. And that's a great place to bring in Dean Watkins Hayes. So where do we, what do health policy people do with information like the information in this book and all of the studies and findings it comes from?
First of all,
I think, turn on the mic, yeah.
thank you so much for this discussion. I think it is so helpful in so many ways. And actually, to answer your question, I want to pick up on what you just said, Linda, about the current generation asking for something different as it relates to medical education. And I think that as a university, we underestimate our ability to shape things because we do operate as gatekeepers, right? We teach undergraduates who want to go on to medical school and who are incentivized to do certain things to go into the medical school of their choice. And one of the things that's been really interesting that I've been tracking is the number of students who are interested in medical school who are in my sociology classes and see it as whether for a requirement, whether for really wanting to have that understanding, whether they see it as a leg up, however the incentive system is working. Students recognize the importance of understanding these historical and sociological and political dynamics that shape the field that they want to go into. So to the degree that we can institutionally encourage and support that, for a generation of students who will be the next generation of healthcare workers, I think that's where universities can be extremely impactful. Because that ability to set the terms under which someone is going to be able to get an education as a healthcare provider, and to be able to say it will be grounded in a historical analysis, it will be grounded in a sociological understanding, and one will have those, that is part of their toolkit, just as they have biology and chemistry and all of the other fields, I think is really important and valuable. From a larger policy perspective, one of the things that I find really compelling about what you shared is this idea of widening access to a system that's broken will not fix things. And I would love to hear you comment on the variety of proposals and options that look at either of those, thinking about widening access, when we think about Medicaid expansion, when we think about Medicare for all, when we think about the states that didn't choose to expand Medicaid and the health outcomes that we're seeing. I wonder if you can comment on the missed opportunities as it relates to access, and I wonder if you can comment on the missed opportunities as it relates to the quality of delivery of the system. And then I also wonder if you can talk about the things that excite you and resonate with you in terms of some of the most important policy interventions we've seen.
I am really interested in how we learn from communities and how we learn from nations that that have fewer resources than we do. And what happens in our country is the investments go into technology, into sort of clinical innovations, without looking at what other countries are doing with like community health workers. And I was in some countries in Africa shadowing community health workers saying, oh, this is so beautiful, the care, the kind of, sort of preventive care that they provide, or, different kinds of giving vaccines, mosquito nets, these kinds of things. And I'm like, America, we don't invest in that. It becomes, some community health workers, they don't even have a sort of a common name. They're called doulas sometimes, community health workers, patient navigators. So we haven't institutionalized that, because there's an assumption that if we just doctor our way out of these problems, that's the solution. When sometimes it's a kind touch, it's someone that you trust that is from your community, or even having some experience with whatever problem you're dealing with. And I'm really interested in Dr. Harold Freeman, who is an early mentor of mine, and his patient navigator system at Harlem Hospital for people who are dealing with cancer. And that is something that could be institutionalized. And community health workers should, or however we call them, should be part of the system. I was shocked that the woman who I was with during my maternal mortality story, the doula that really saved her life, that was with her for months on end, only made $600. So another, policy could be paying people for the work that they do and saying doulas should be part of the OBGYN experience. And I think that those things are really important. And I also want to lift up, places that have done it. The state of California has made implicit bias training, at best it's anti-racism training, part of continuing medical education for anyone who is in the healthcare system. And I think that's really good, is mandating it. The state of New York, when Mary Bassett was our Commissioner of Health, mandated anti-racism training, and it was extensive to all 7,000 employees at the Department of Health. And you see that in pockets around the country, but that was, being the biggest city, that was an important, something for her to do, to model for other places. And I also, when I was talking to her about this, she said, well, you didn't even go far enough. I did more than that. I was like, okay. What she also did was to say, look at the communities where the need is greatest and put the resources there. And that doesn't seem like it would be, it's not like
rocket science.
Not rocket science there, but just doing it, making that happen and insisting on it when you're the person at the top was really important. I said, how did you do that? And she said, there was a map of the poorest places and poorest health outcomes. She looked at that map and she said, this is where we're going to put the money. That is so totally not rocket science, but it's something that doesn't happen in other places.
And can I ask a follow-up question? In the Ford School, in our policy conversations, we try to remind students that policy is happening at the federal level, state, local, also within institutions. And I wonder, as I listen to you, it sounds like you have the most optimism at the kind of the local, institutional, and perhaps the state level. But I don't hear as much optimism in terms of the federal interventions that can be made. Is it because of our current political struggles? What are your thoughts about that? Should we continue? How do we continue to think about interventions at the federal level, or is that
I think that is so hard. I almost said fool's errand, but no. I'm optimistic. It's so hard. I mean, why hasn't that omnibus bill passed? That should, that would make huge differences around the country.
I don't know if people know what, the word she said is the momnibus.
So it's a bill that's, it's a national legislation that has not passed yet to sort of look at the maternal mortality crisis in America and put some legislation behind it, including anti-racism training for providers, and that hasn't passed. I got real discouraged around Roe v. Wade because you can see that train wreck happening around reproductive justice. So it's not just about abortion. It's about the right to have a child, the right to not have a child, and if you do choose to have a child, to have a healthy child. So if you take away reproductive health services, that's not just about abortion. And it hits worse in Mississippi, where it happened, is the poorest state, has the highest rate of child mortality, has high infant mortality. All the bad things happen, and then you close the place where people are going for care. And I just thought, ugh. I was in Aspen, which I love. I'm from Colorado, so that's like my homeland. And I felt myself getting really sad that day around Roe v. Wade, and I started to lose hope. And then I was at the Aspen Ideas Festival, and there was a woman who was from West Virginia. And West Virginia, where I'd spent time, she said, we're going to lose our clinic. And then she said, should we take it underground? I'm like, yes, yes, obviously, if that's your only option. And then you saw the young folk in the room light up, and you could see them going, ooh, how can I get to West Virginia? Help with the underground, people getting reproductive health services. And that kind of, I felt up again, because I just felt like, oh, there is some hope. People want to do better. They want to be involved in the change. And many of them are people who are just getting started in their careers. And that gave me hope again.
I want to make sure we're bringing in questions from around the room, because I see people writing, and I don't know if you're taking notes for later or writing question cards, but do you have question cards here, Makita?
This question is from someone who's affiliated with the medical school. And it's similar to another question from a physician in the audience. It says there appears to be some distrust within the Black community toward the medical system. How much do you think that contributes to poor outcomes, and how can we overcome that?
Well, I think it is a contributing factor.
Did everybody hear the question? Yeah.
If people,
Could we just, I want to repeat it, that the question, 2 questions from healthcare providers about lack of trust in the system by Black people, and how can that be overcome and addressed?
and I think it does make a difference, and I think how you think about it is there's a lack of trust for a reason. So it's not just because people are paranoid, it's because things happen to them in the context of the healthcare system. I was on a panel with, at a famous public health school recently. So it was me, physician, and we were talking about inequality and injustice in healthcare, unequal treatment. And one of the physicians turned to me and said, I think people like you should just do more research in this area so you have more evidence to prove that inequality and injustice in healthcare is a thing. And I'm like, I usually would never pop off at the famous public health school. And I'm like, no, we don't need any more research. There's plenty of research. The unequal treatment is 20 years old, and it's the gold standard piece of documentation that 20 years ago looked at 483 studies around inequality in healthcare. Most of the studies had people matched by access to healthcare, and it was without a doubt proven by this evidence, this huge document, that Black people and often other people of color just receive unequal treatment across the field. So of course, unless you are completely, like you're not listening to that, you're ignoring what people are actually saying, then of course you're distrustful of a system that doesn't treat you well. So that I understand why people are avoiding the system. But also if they're being treated unfairly, then something's wrong with that system.
And about remedies. How do we address that?
I think the way we're trying to address it, one of the things is to insist on some kind of implicit bias training or anti-racism training for people who are working in the healthcare system, and also to not bury, to not be defensive about it. To say this is part of the experience. People are telling you that this is the experience they're having. Listen to them, and make change.
And I just want to, Makita, before we go on, there's an anecdote that you share in the book that I'd love you to share here, because I think that even though we're saying that these kinds of issues cross socioeconomic strata, I think that maybe there's a tendency to believe that the toughest encounters are from the people with the fewest resources. But you tell a story of your father, who was a scientist, developing dementia, and your mother calling you to the hospital. Can you tell that story?
And I wouldn't even say he really had dementia. He was just really upset. He was in the hospital. He had colon cancer, but he didn't know he had it. He just knew he was really ill. So he checked himself into the Veterans Hospital in Denver, where I'm from. I was working at the New York Times. I got a call from my mother, and she said, you need to come home now. You need to put on your nice clothes, make sure you're well dressed, put your New York Times business cards in your pocket, and I'll meet you at the airport. She was dressed up really nice too. And I said, what is going on? And they said, your father is really ill. He's in the hospital. They're treating him like an N-word. She said the word. We go to the hospital. My father, who is impeccably dressed, trained as a scientist, who's really mild-mannered, like his favorite thing was fishing. He's really patient. He's like just a nice person, good sense of humor. He is really agitated. He's super upset. He's freaked out. His gown is really dirty. And he had restraints. He was restrained to the bed. And I just thought, oh no, what has happened here? My mom said, we need to go home. We got his medals from military service. He was in the Navy. He has a Silver Star. We got pictures of him before he was ill. We got his college degree, and we explained to them, if they speak to him in a kind way, if they are patient and explain what's going on with him, he won't be agitated. But I just thought, he is being perceived as someone who's angry and out of control, and there's no kindness given to him. There's only the assumption that he's dangerous, even though, he was not young, he was not really going to harm anyone. But I just thought, wow, if my father, who is so educated and just given so much service to his country, gets treated like this, then something really is wrong with this system.
I also, my mother died of cancer, and I learned during her illness, and now my father's ill, that I have to dress to go to the hospital.
Oh, yeah.
And I also take my business cards. And I remember coming back from a trip to Ohio and talking to the staff about how frustrated I was when I walked into the room at how my father was being spoken to. And how hard it was to turn the conversation around. And finally, at one point, I said, well, I'm a journalist. Do you mind if I start recording? And it was the only way I could flip the tone of the conversation, and to where they were speaking to us as if we had the capacity to understand the details of what was wrong with him. And, you shouldn't really have to put on a suit to go to the hospital, but yeah.
Yeah.
I thought it was a story worth sharing.
Yeah.
Another question?
Yeah, there's a ton of questions. Here's one from a Ford School student, and they ask, what role, if any, does preventative care play in ensuring more positive and equitable health outcomes in the Black community and communities of color?
I think that everyone should take care of each person should take care of themselves, and we should take care of other people that we love and that we care about, our friends, our family, our neighbors. I think that's really important, but it still won't it won't change the structures that are broken. But it will make individuals happier and healthier. And what I think is, if you just really take good care of yourself and you do the things right, then at least you can avoid encounters with the healthcare system.
And this tone of question is coming up a couple times. This one is from a PhD student in sociology. Is there evidence of the effectiveness and results of implicit bias and anti-racism training for medical professionals? What else can be done in medical systems or settings to address systemic racist treatment of patients?
I think I'm going to say I don't know. I'm a journalist, and what we do is cover bad news. That's really great, something's terrible. So I lean into that a little bit more. It was funny because I wrote this book in chronological, in order that it's here. So the solutions chapter is the second to the last one. So that meant I was kind of a little rushed, a little bit late, a year and a half late, kind of in trouble for missing the deadlines. So I think I wish I could go back and do more research on sort of the idea of the programs that work, or the solutions that work a little bit more. But I do believe I believe that this training cannot be wrong. And if people, especially because I see the level of denial in some of the encounters I've had, where these people, if you are working in a community of color and you're not from that community, even if you're a person of color, you need to know who the people are, where they live, how they live, and that kind of thing. I think interesting solution that I've seen is when the hospital system is very involved in the community. In other words, a lot of the best hospitals are in the worst places, and then the community around the medical center is impoverished, or it's has poor health outcomes. And it's what is the responsibility of people, of healthcare providers who say they are trying to make people healthier, to the community that needs them? And so I think that is sort of it's not really in the mandate generally of a hospital or a clinic, but that is one way that I've seen where there's a lot of back and forth. And I think listening to people as you try to find a solution is just the simplest way to start.
And I want to do a little bit of crowdsourcing here because I do know that we have at least one section in the room here from Michigan Medicine. And so would you have are there solutions that any of you have seen, and we can pass the mic up to you, that work and that could be implemented more broadly? And please introduce yourself.
So I'm Lori Pierce. I'm a physician. I'm a radiation oncologist. I treat breast cancer, and I am so happy to be here, and I so appreciate this discussion. It's a very rich discussion. There's so many touch points. I've been taking notes, saying, oh, I want to say this, we want to mention that. But I think part of the solution is having more providers that look like the patients that we serve.
Yeah.
That said, not every black patient needs a black physician. I think all physicians need to be more culturally competent, which is what you're saying, and implicit bias training is important. But I found that some people think implicit bias training, okay, I've done it, check, I don't have to do it again. It's not a one and done thing. You know, you do it over. Every time you do it, you pick up more and more, and you enrich yourselves, you enrich others. So that's one thing. And you've hit upon this so many times. It takes a village, right? It's a conversation. It needs to be bi-directional. We need to bring the community in and be listening. It is so important to listen to what patients say. Patients know what they need, and we as providers need to listen to that. And it's not always the physician. You know, we need to have
That's right.
teams because we have nurses, we have physician's assistants, we have others. And sometimes patients gravitate toward those individuals more so than the physician, and also they may have more time than the physician. So it takes a village. So, you know, this is very, very complicated, and it's so important that we don't talk at people, that we talk with them. It takes a community, and I think these types of discussions are so important. And I'll also say one more thing. Medicine is a hard nut to crack, but it's cracking. I really think that it is. And I look at our medical students as being strategic disruptors. They've got it. They are, as you said, they are mandating change in the curriculum. They are aware of things that many of us 30 years ago were not. And I take my hat off to the students that we have in the undergraduate and in the medical school because they are change agents. If others want to say anything.
Thank you so much. I'm Tony Denton. I'm the Senior Vice President, Chief Operating Officer for University of Michigan Health, and Lori Pierce's husband. But we're really focused on equity improvement and what it means. And part of my responsibility for the enterprise, it includes community outreach, to the point that you're making. But it starts off, I think, with identifying it as an anchor institution. We have a responsibility to community. We were very intentional 3 years ago in saying that racism is a public health crisis. And to acknowledge that and to say it out loud means that we have the responsibility to then respond with actionable strategies, which includes leadership from our Associate VP for Diversity, Equity, and Inclusion, David Brown, who's 2 doors down from me, as we work together to try to create actions that cut across the organization. Certainly it includes implicit bias. It includes partnership across many different schools within the institution. It means partnership across industry. I'm also the chairman of the board for the Michigan Hospital Association, where we've adapted and adopted priorities because this is, for us, a statewide issue. And so we are banding together as healthcare leaders that helps bring teeth and strength to what it is we're trying to change. And that includes connecting with the media to speak out loud about what's so important for us to do. But you made a really important point about community health needs assessment. We identify the needs of the community. We've adopted Ypsilanti, which has for too long been neglected in terms of equitable access to care, and to create, I would call, this anchor strategy, the Healthcare Anchor Network. It's a consortium of 70-plus healthcare institutions around the country that agree that it's important to not only uplift to create better health, but community wealth.
Yeah.
And in doing so, you get to the root causes that tie to poverty that gives us opportunity to invest more locally in terms of hiring, suppliers, investments in infrastructure, to create a higher economic base and to give people more choices, which it includes more choices about health and prevention. So it's really a systematic effort. Obviously, it takes a long time. It's a journey, but this is where we're starting to try to build blocks to improve access, to improve education, to elevate, to empower, in order to create change that is really tied to being meaningfully present. And so our theme is building bridges and connecting communities. And as we think about the different tactics that tie to that as a strategy, that's how we mark ourselves, how we measure ourselves in terms of being a leader in the community, because we believe that we are of the community.
Good. Thank you for that.
Thank you for this conversation. I'm David Brown. I'm the Associate Dean and Associate Vice President for Health Equity and Inclusion at Michigan Medicine, and I'm a pediatric ears, nose, and throat surgeon, and I'm not related to Lori Pierce. But still love her. And thank you for bringing up the conversation about implicit bias. The state of Michigan requires that training here as well, and I was on a task force for that. And we realized that that's just the beginning. As part of it, we have to teach about how racism and bias impacts healthcare and how the history of health disparities. However, I feel that implicit bias is the awareness, and what we really need is the actions, and those don't always come. So what we really need on top of that is the accountability. And so Susan Moore, who you spoke of, is a graduate of our medical school, actually.
Oh.
Yes, and so it really touched us when she passed away. And there were some department chairs saying, we need to have a lectureship for her. And I said, that's great, but in 10 years, we'll forget why we're having this lectureship. And so what we decided to do at Michigan Medicine, being innovators and change agents, we hope, is not in her honor, in her name, but to honor what she went through, we created a health equity consult service, which we think is the first in the country. Susan Gould behind me is a member of the team, and there are many other members of the team. Is actually headed up by an African-American obstetrician, Dr. Okyama Memeje. And what we're realizing, anyone can call this consult. Patient, their family, environmental services, someone just walking down the hall seeing an inequity. And what we're finding is that even though people have had this training and they know it, it's so subtle. And when we peel back the multiple layers of bias and racism that they can't even see, there's so many aha moments. And I think we have actually saved lives and changed outcomes for people, including people who are complaining about pain and people who are not being considered for major procedures. And so we just submitted our first few abstracts and writing a paper on this, and we hope that other people like ethics consults around the country will consider this because it's much needed to enforce the accountability.
I don't want to make this a Michigan Medicine thing, but I want to say one more thing, particular to the students. Don't give up on advocacy, even at the federal level. It takes time, but change can happen. I was president of the largest cancer organization of cancer providers in the world, and we and other cancer organizations partnered together in the U.S. to get the Clinical Treatment Act passed, and that, very briefly, was an act that said Medicaid patients deserve the same benefits that Medicare patients and those with private insurance. Clinical trials, being on clinical trial is so very important in cancer care. And patients who had Medicare, patients who had private insurance, had all charges covered. Medicaid patients didn't have those charges covered, but if they didn't go into clinical trial, their charges were covered. So it was a disadvantage. They were disadvantaged if they went on clinical trials, which made no sense. And so we got together and we fought years and years, and we got it passed. And it was such a big victory. But it takes time. It takes commitment, and it takes time. So I say to all of you out there, you are the change agents, and at every level, advocacy does matter.
Thank you.
I just want to say, just because a lot of the frame that we've been speaking around today has been black and white, but implicit bias training is often it needs to be cultural training that crosses over many different communities. One of the things that at Wallace House, we bring journalists from around the world every year. And I help people get set up here in Ann Arbor. And in 2021, we had someone arrive from a situation of extreme unrest in their country, pregnant. And so one of the first things I needed to do was help the woman find prenatal care. And she's a Muslim woman, and I said, what are you looking for? What do you need in a doctor before I start? And she said, I'm not very religious, but it's really culturally important for me to have a woman. I said, I get it. We should be able to do that. And I went with her. We got an appointment, and I went with her, and the doctor came in and started to do the intake. I had asked for permission to be in the exam room with her because I knew that she was still very recently traumatized. And she said, will I be able to have a woman present at the birth of my child? That's all I really care about. And the doctor, from a very American framework, went into kind of a gender equity speech about, at Michigan Medicine, we don't have, we can't guarantee because that would, if we can't let a man and the woman in the room, then, that would be gender discrimination, and just like a long sort of public service announcement about gender equity. and I could see just the fear going through her, the woman that I had brought to the appointment, and the conversation she just kept talking, but was not reading the room in any way. And I said, I think we've got it. And we finished the appointment. I said, what blood work does she need to have done today? Today we need to establish where she is in her pregnancy, make sure everything's healthy, and then we'll take it from here. And we got our blood work, and then we went to the midwife's practice at St. Joe's because it was just a different. In the end, they still arrived at the same place, which I think what the doctor was trying to say is, if there's a complication in delivery, we can't guarantee that a man might not be brought into the room. But at the midwife practice, they sort of took her in first, sort of established her situation, talked about her needs in the birth, and they said, well, here, we're midwives and we are all women, and here's what we'll try for. And if for some reason there's a crisis at delivery, and then she said, that's okay, that would happen, and then she said the name of her country, that would happen in my country too. If I needed an operation at the end, maybe a man would come, that's okay. But can we start with a woman? Huh. And it was just sort of cultural, a lack of cultural understanding in the first instance. And so I just want to put that out there, that sort of cultural competency and implicit bias training cuts across race and religion and class and all of these things that sometimes we don't realize we're not sensitive to. Yeah.
These questions are, I think, connected. One comes from a licensed clinical social worker, and the other a student in the College of Literature, Science, and Arts. How can someone outside of the medical system, medical school, outside of the policy school help with this issue? And how do we collectively act to use this insight to affect change?
Well, I mean, one thing is you can provide loving support for people around you. Community care, kinship, that kind of, all those good things to other humans that you love and in your life, especially during birth and pregnancy, but also if having to enter the healthcare system. I think when we were talking earlier, you said a thing that struck me is like, when you go in, when you enter the healthcare system, you put on a gown and people don't see your business suit that we were so careful to be wearing. And I remember this happened to my best friend, where she is a millionaire. But when she went in to have her baby, they started asking her about her Medicaid card. on and on. Not more than one person. I was like, what? They did not know they didn't know who she was. But that struck, I mean, not that you should get better medical care because of your wealth, but that struck me because everyone is stripped down. So and it's fearful, you're not clothed. So it's good to have someone else. I think the other thing is, I think a lot about those women and people who protested against Dr. Sims's statue. They were just people who said, I can't deal with this. I don't think we should celebrate him, and went out, sustained protests and that statue got removed. So I think you can find ways to be active in this, and also to listen to people who are talking about their experiences, and support medical students. Yesterday I was giving a lecture at a medical school, and two guys came up and they said, we walked out of our lecture. It was on nephrology, and the professor was talking about the kidney function disease that has a race correction. And so they said, why would black people have a correction on their kidney function? He said, oh, that's just how it is because black people have more muscle mass. I said, wait, the professor said that? Black people have more muscle mass, so that means that, in the end, they have a different kidney function. And the kids kept saying, why? How do you know that? Where did that come from? And he wouldn't engage. He just said, it's in the textbook. And this is recent. This was a couple months ago, and they walked out of the class. And now that school is making conversation about not teaching that, false idea of the unnecessary race correction.
Can you explain, though, race correction for people in the room who might not know what that is?
So it means that, even it happened to me. I had a kidney function test, so then I got the results back, and then it said, if you are a black patient, if you are a white patient, and the black was circled for me. So I had a different reading based on my race, and it's under the assumption that people with more muscle mass, oh my God, what is it? Secrete more creatinine, and then I think it falsely rises your kidney function. So that's really not good because black people have worse kidney disease. So that could leave you off treatment if your kidney function looks falsely positive. And, but I was surprised when I never had paid attention, and I was like, oh my God, I got the correction that changed my test based on my race. And obviously, someone like me does not have a lot of muscle mass, but then why would mine get changed and not, Arnold Schwarzenegger or whatever, you know what I mean? Or a white bodybuilder. So that makes zero sense and is wrong. And I'm really happy that those students walked out of the class and made a statement, even though they could get in trouble.
There's a few questions from Knight Wallace Fellows, so they're kind of about storytelling. This one says, your New York Times Magazine story, Why America's Black Mothers and Babies Are in a Life or Death Crisis, was a beautiful and impactful portrayal of Simone Landrum's pregnancy. As a reporter, how do you approach such intimate stories that need to be told without re-traumatizing or victimizing your subjects?
I thank you for that question. I worry about it a lot. What I try to do is have a set of questions that I ask when someone's having to tell a story of something horrible that happened to them. And in her case, she had gotten pregnant. Her legitimate concerns about what even a layperson could recognize as preeclampsia. She said, oh, my hands and ankles were swollen. My face was swollen. I had headaches. And then I looked at her medical records. Even in the doctor's office, she had high blood pressure readings. So preeclampsia meant that instead of, she thought when her water broke, it was blood. And her baby was stillborn, and she almost died of blood loss. So she had to tell me that story, and it was super painful for her. So I had her just tell me once, I'm really listening, I'm recording it, I'm asking questions at the time, and I tried to approach it with sympathy, compassion, deep listening, so that it was, and saying, I'm sorry that happened to you, it wasn't right. But it's hard. I I interviewed a woman whose husband had died of COVID. His funeral was Friday, and I interviewed her on Monday. So she was raw. And it got picked up for the daily podcast. So, usually if you're the journalist in the room, it's kind of unpleasant to listen to yourself interviewing. But I was really proud of myself because she was from New Orleans, and I had slowed way down. I wasn't talking fast. I was letting her lead the conversation. I was, trying to sound compassionate. It was over the phone. And that's what I try to do. And, I said, let me get everything that I can right now so that I don't have to call back and ask more questions, because I know she's going to have to answer some of the same questions again in fact-checking. So she's going to have to retell that story to some extent to someone else. So let me get as full of the picture as I can one time.
I do want to acknowledge for the journalist in the room, or even people interested in journalism, the kind of stories that you do have not necessarily always been easy to get into the pages of the New York Times. We've had our own struggles,
Yes.
sometimes, to tell stories in the way that we thought that they should be told. Yeah.
I think that, I took a page from you where we were pitching a story on HIV/AIDS, and it was a story that was coming from the community, so our editors didn't know about it. By then, in the early 2000s, it was about Black women, and it was about high death rates, and they weren't seeing it in their lives, even though we, as Black people, were seeing it. They were thinking that the problem was solved, that it had moved to Africa, and it was like, oh, we have an African correspondent. We're like, this is in the U.S. And they just didn't believe it. And thanks to you for pushing back, because I was giving up. And you were saying, no, we're going back. We're going to have more evidence. We're going to be more forceful about this story. And we ended up getting those stories in the paper.
On the front page.
On the front page.
Yeah.
My
Yeah.
mom bought all the copies out.
Yeah, yeah. But it was, I do think that, hopefully there would be less of this now, but if it wasn't something that had been discussed in a cocktail party on the Upper West Side, and so therefore
It doesn't
It didn't
exist.
exist. And, you have to, so in every field, you have to know when to keep pushing. I assume it's the same in academia. Yeah.
Kind of in line with that is my own question, but I'm curious about the difference between you reporting on these stories at the New York Times versus Essence. How was the work received? What kind of impact did your work have with these two very different outlets?
So much, so much easier to get the stories into Essence, obviously. You weren't having to prove everything because many of us knew what was going on in the community already, and it was one of the charges that we had. I think it was always fun when my stories came out in Essence, because I knew that people that I knew would read them, and it was easier to, it was both easy and hard to get people to talk about their lives in the pages of Essence, because they knew everyone was going to read it. Remember, I told Simone Landrum, I said, are you sure that you want to tell your story, because it's going to be in the New York Times, it's going to be on the cover of the New York Times Magazine. She goes, nobody reads that. Nobody reads the New York Times here. And I'm like, your governor does, your mayor, and you should be reading it. But it was, I like both. Very early in my career, at my first job, I had a really hard time with my supervisor, who just really wasn't giving me a break. Behind my back was calling me an affirmative action hire, and was telling other people not to give me a chance because I had no talent. So then I left there. I was able to put her aside, because I knew that that wasn't true. And the first New York Times Magazine cover story, she was the first person who went through my head, because I just thought, ha, 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 she still lives in New York. Now that's going to land on her doorstep with my name, who has no talent. She never was writing for the New York Times. So all the shade just came out in that.
I want to make sure that we end on time, and I want to make sure that people have a chance to get the book and have Linda sign it. But, you know, again, I want to underscore that this came together today because Celeste and I had a conversation just about the issues that we care about and the things that we wanted to do together. And Celeste is now on the Wallace House board, which I'm very happy about. But Dean Watkins Hayes, I just want to, as the founder of the Center for Racial Justice, give you an opportunity to have some closing thoughts on the conversation today and your mission here for the priorities of the university as well.
Thank you so much, and I so appreciate our partnership. And the Wallace House is doing such important work at the university, but also for journalists all over. And I remember an event that we did, and you talked about, it's called the Wallace House Center for Journalists for a reason, because we know that the field has been under attack in terms of people who don't want to know the truth and want to undermine and undercut the work that you're doing, or not financially support it when we think about what's happened in terms of local media and its real struggles financially. So I just want to affirm this wonderful work, and I want to say in forums like this, it is often easy to get depressed. But I think about these as our filling stations because we're sharing information, we're sharing ideas, we're sharing a language that we will then take out into other discussions in critical moments. We might find ourselves in that classroom where we make the decision to leave. We might find ourselves in the examining room or in the waiting room observing an interaction that is inappropriate. We might find ourselves as institutional leaders who get to think about where the resources go and why. So these conversations give us the content and the foundation to be able to then carry out the work and carry out the ideas and influence organizations and institutions in really critical ways. So I always think about these as I always learn something new, but I also am reminded of things that I already know and am reminded of why I need to make those critical interventions. So for many of us in this room who think about these issues a lot, you've offered so many useful reminders. And for those of us who are new to the topic, you've offered us so many important ideas that we will now store in our toolboxes. So I just thank you so much for this work. And I thank you for the team from Michigan Medicine and my colleagues here at the university, and Makita Easter, who is a fellow at Wallace House and the Center for Racial Justice, and just another example of the collaborative work that we've been able to do together and the good trouble we've been able to get into here at the university. So I want to thank everyone for being here and for coming and for holding space for this really important conversation.
Thank you all.
Thank you. Thank you.